when my PC died. Now? Mm, okay, I'll just do it. Are you recording again? Yeah, okay, then I'll do it. Where were we? We were talking about breast. Yeah, okay, so we did this X-ray. So here the lesion is actually over here and not here because both of these opacities are symmetrical and they indicate breast tissue. And this is where the pneumonia is. It's in the right upper lobe. Okay. Yeah. Okay. And then we went to the next X-ray over here. In here, there's an opacity over here, which is more asymmetrical as compared to the other side. So this is right lower lobe pneumonia. And there is also some hilar adenopathy again. Then, okay. How come I cannot hear anything? Anyways, okay. Then we did this X-ray. In this X-ray, we see that yeah, we see spine sign. So basically, what this spine sign means is so in this X-ray we can see in the PA view there is an opacification over here, and there is no silhouette sign. It does not touch any of the cardiac or the diaphragmatic silhouettes. Okay, but in the lateral view, we're able to see normally in the lateral view as we go down, the vertebrae become more translucent. But if we see an opacification in the vertebrae in the lateral view, it indicates an overlying consolidation in the left lower lobe. So that can indicate left lower lobe pneumonia. This is called spine sign. Okay, spine sign. It's okay. So over here. Okay. Then we'll go to bronchopneumonia. So in bronchopneumonia, there is patchy opacification. Okay, and it can involve it can be bilateral. Then there'll be no air bronchograms. I mean, there usually no air bronchograms. Amber says that it can be there, but then some other places say that's not there. Okay, then yeah, and it will be ill-defined borders. Okay, so it'll be all patchy like this, and it's better appreciated on a chest CT. Okay, then yeah, so that's bronchopneumonia. Okay, so over here, where do you think the lesions are? It's a little bit hard, I guess. In this X-ray, where do you think the lesions are? Yeah, in the right middle zone. That's correct. Yes. Okay, so ill-defined opacities in the right lung and perihilar opacities in the left. Some perihilar opacities are also there. So they're bronchopneumonia. Okay, that's nice. Now, what is the next? Okay, now this is the third type of pneumonia. Mm, third type of pneumonia is called interstitial pneumonia. So that is basically, like mycoplasma, viral infections, like the walking pneumonia. Okay. So in walking pneumonia, there'll be no consolidation, there'll be no air bronchograms. But what you will see is, well, I hope it doesn't crash. And what we'll basically see is diffuse reticular opacities, like over here, you can see. So how do you check for reticular opacities is, like, how do you differentiate reticular opacities from the normal lung markings? Okay, so basically, yeah, around the alveoli. I guess. So basically, what it means, what usually happens is, 1 centimeter from the pleural margin, like approximately over here or over here, the lung markings are supposed to like this area is supposed to be cleared. They're not supposed to be all these lines stuff over here. Okay, but if there are all these reticular line stuff over here, that means there is reticular lesions in the lung. Okay, so that's how you see. Okay, so diffuse reticular pattern is there in interstitial pneumonia. Okay, once more. Okay. Yeah. Okay. So basically, in a normal chest X-ray, the pulmonary vascular markings, they will only extend to a certain extent. Okay, like almost like a 1 centimeter distance from the pleura. Over here, this area will be relatively clear. Okay, there will not be any reticular lines which indicate the pulmonary vascular marking. But if they are present, they will be present if there is diffuse reticular opacity. So over here, you can see this one, this one. What is this X-ray? What is the diagnosis? From this? Okay. Okay, so in it's seen in okay, then yeah, stop. Okay, okay, complex. Okay, okay. Then this is like the reactivation of primary TB. Okay, oh, what happened? Okay, so here you can see like these cavitatory lesions. Can you see? Okay, this is fibrocaseous cavitary lesions in the upper lobes, like the okay, secondary TB kind of post primary TB. Yeah, that's what it's called. Okay. Okay, now what is this? What is this X-ray? Anybody? Okay, mostly nodular, mostly very small, less than 3 millimeter, nodular diffuse opacity. What do you think it is? It is kind of nodular actually. Diffuse nodular opacities. Yeah, yeah, but what TV? Why? I took this from Google only, Falcon. There were many other, like all the X-rays look different only actually. Couldn't get anything very typical. Okay, 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 fine. You can send it after the class. I have written the diagram. Okay, so it's like, yeah, like in liver. Okay, then this is what is this? Yeah, it's a cavitatory lesion with an air fluid level. So it could be like a it could be a lot of things actually. It could be a cavitatory TB, it could even be a malignancy, it could be a lung abscess. Okay. Now, yeah, abscess. Okay, so suppose if it is a lung abscess, okay, why is it like usually what is the most common cause of lung abscess? Aspiration, yeah. So if there is an aspiration, which lobe is most commonly affected? Yes, right lower lobe. Okay, but then why is it so? Suppose so, why is right upper lobe involved? Suppose this is a lung abscess. Okay, so is there any case in which yes, if it's a recumbent, that is right. If the patient, yeah, if the patient is recumbent, then right upper lobe can also be affected. Okay, you guys know that. Okay, so this is a lung abscess. Okay, so in upright position, it's right lower lobe, and it can be right middle or right upper lobe. Okay, now what's this one? Yes, apart from those, the pathology. Right, upper lobe is correct. What is okay? So what do you see? What does it look like? Yes, heart is kind of big. That's true. Okay, apart from that, okay, so this is the lesion, and there is kind of a translucency around the lesion. Okay, so there's a cavity and there's an opacity inside that. Okay, it's kind of a pneumonia. Do you guys know which etiology? What can be the cause of this pneumonia? Fungal. Yes, this is aspergilloma. Aspergillus fungal ball. Okay, so this is called air crescent sign. And there is an opacity, and then there is like a translucent area around that opacity. Okay, you hear this thing called the air crescent sign. You can see in an aspergilloma. Okay, and then apparently there are also diffuse reticulonodular opacities. So I could not see, but apparently these are opacities. Well, it is a crescent. Look, I'll draw it for you. That is a crescent, like a crescent moon. Okay. Mm. You guys just see all the wrong things. Anyways, um, yeah. Okay, so now we come to atelectasis. I think this is the last main topic. Okay, so atelectasis is basically reduced inflammation of part or all of the lung. Okay, and there are some radiological signs in atelectasis. The most direct sign, like the most, what do you say, like the correct sign. Okay, like the most definite sign of atelectasis is basically shift of fissures. So if suppose if this is the lung, okay, and this is like the fissures. Okay, so if this part of, if this lobe, or if this one part of the lung collapses, then that will cause the fissures to shift from one place to another, depending on which lobe has collapsed. Okay, so that you'll be able to see that on the chest x-ray. Okay, if you're able to see that on the chest x-ray, then you can know which part of the lobe has collapsed and if there is an atelectasis. So that is, this is the definite sign of chest x-ray, of atelectasis. Okay, increased lung opacity is basically the part of the lung that has collapsed, it'll appear more opaque. Okay, then there'll be compensatory hyperinflation, which basically means that if if one part of the lung is collapsed, the other part of the lung will try to expand more into the area that is available, and it'll appear more translucent. Okay, so there'll be compensatory hyperinflation of the areas of the other areas of the same lung, or it can also be of the different lung. Okay, then if suppose if there is atelectasis over here, the collapsed lung might like pull the hilar structures above, or it might pull the hilar structures below. Okay, so that there will be a hilar shift, or it can, there can also be a mediastinal shift. Okay, again, if there is a collapse, the diaphragm sometimes might get, what do you say, pinched up. Okay, so that will be, there'll be an elevated diaphragm. In the area of collapse, there might be crowding of ribs. Okay, or crowding of pulmonary vessels. So these are like indirect signs. You cannot say for sure that if these are present, that atelectasis is present, but these also indicate that atelectasis is present. For sure, it's if it is there if there's shift of fish. Okay. Now there's classification of atelectasis based on etiology, and then based lungs that are the part of the lung that is affected. So based on etiology, there is post obstructive, there is compressive, cicatricial, adhesive, and passive. Okay, so we'll discuss each of these. In post-obstructive atelectasis, basically it means that there is some intra-lung pathology that is obstructing the bronchi. Okay, so there is an obstruction. So the alveoli distal to the obstruction, they're not able to get any more air inside. Okay, and so basically whatever air is left, it gets resorbed by the lung. So now the left that is air that is remaining, it gets resorbed by the lung, and then it causes atelectasis. Okay, so this is post-obstructive atelectasis. Okay, so basically, what causes these obstruction? It can be a tumor, it can be a mucus plug, it can be foreign body. Okay, any of those things will cause an obstruction, and then suppose this is the alveoli and this is the bronchi. It causes an obstruction. Now, whatever air is remaining, it'll get resorbed. Okay, and it'll get resorbed and it'll cause an atelectasis. So then then this alveoli will shrink. It will cause an atelectasis. This is called post-obstructive atelectasis. Okay. Over here, there is an atelectasis of the right upper lobe. Okay. All right. Now, next one is compressive atelectasis. Compressive atelectasis is different in the way that it has like a really big lung pathology, a very big lung pathology. It basically pushes the air out of the alveoli around it. So suppose this is the alveoli and there's some very big mass kind of like, I don't know, compressing it. So then no air, whatever air was can come inside. So that is compressive atelectasis. Okay, so the mass is over here, and the lung area surrounding it will have consolidation. So that is compressive atelectasis. Compressive atelectasis. Okay, yeah. Okay, so basically, like a large tumor or large mass, it kind of what do you say, pushes the air, whatever air was there in the alveoli, out of the lungs. Okay, so suppose if there is an alveoli, this is the bronchi, and there's this mass compressing over it, so whatever air was there will go out, and and no air will be able to come inside also. Okay, so basically around the mass, the alveoli that are present, they will have atelectasis. Okay, so that is compressive atelectasis. So not distal but around it. Okay, like over here, I'll tell you, over here the mass is actually only around here. Okay, this is the mass actually. Okay, but the atelectasis is all the way here. Okay, but here the atelectasis is only around the mass. Like okay, so basically what I think is, maybe post obstructive and compressive can occur together also, and it doesn't have to occur together also. If it does, then yeah, it can be both together. Yeah, yeah, yes. Genius coffee. Okay, next. Then there's cicatricial. Okay, cicatricial occurs because of scarring. Okay, like post-operatively, or because of TB, or because of sarcoidosis. So if there is scarring, it will prevent. If there is scarring of the lung tissue, it will prevent the alveoli from expanding. Okay, so then there'll be atelectasis. Okay, then then the next type is adhesive atelectasis. So basically, the alveoli, they have surfactant in them, right, which prevents them from collapsing. So if there is any deficiency of the surfactant or inactivation, okay, seen in acute respiratory distress syndrome, there'll be surfactant deficiency and the alveoli will collapse. So that will cause atelectasis. Okay, so that is adhesive atelectasis. Like this. This is ARDS, and there's diffuse atelectasis because of adhesive atelectasis. Okay. All right. Okay. The next one is passive atelectasis. Okay, so what is this X-ray? What is this X-ray? What do you guys see in this X-ray? Yes, yeah. Okay, but what else? Something we learned in last class. The diaphragm is, what is it? What is happening to diaphragm? And I'll just show the whole X-ray. Left lung collapse, correct, but bigger than that, more important than that. हम खाएँगे थोड़ी देर बाद. Oh my goodness, guys. Yes, there is shift of mediastinum, correct. There is collapse of the lung. But what is causing all of these? The diaphragm. Yes, pneumothorax, pneumothorax. Okay. Yes. Okay, you guys got it finally. Okay, so this is pneumothorax. Where did you say pneumothorax? I didn't see it anywhere. Okay. Yeah. So this is so in passive atelectasis. Okay, so in passive atelectasis, what happens is that something that occupies the lung intrathoracic space, like a pneumothorax or a pleural effusion, it occupies the what happened? Okay, it occupies the intrathoracic space. Okay, and then because of that, see alveoli they expand because when we inspire there is negative pressure created in the intrathoracic cavity, so they expand because of the negative pressure that is created in the intrathoracic cavity. But if there is pneumothorax or if there is any pleural effusion, there will be no negative pressure, okay, for the to allow the lungs to expand. So they won't be, since they have elastic recoil and they're not able to expand, so if they're not able to expand they will contract. Sorry, my mic fell. Hello, can you hear me? Hello. Yeah, okay. Okay, yeah, I'll just repeat that once again. Um, so basically, the alveoli they require negative pressure, like they expand when there's negative pressure created during inspiration. So if there is a pneumothorax or a pleural effusion occupying the intrathoracic cavity and we are not able to create that negative pressure, then the alveoli will not be able to expand and they will collapse because of their elastic recoil. Okay, so that is basically passive atelectasis. Okay, so there is atelectasis in pneumothorax also. Okay. No, it's because of the pneumothorax that it is compressed. Like it's not visible in this view. Maybe in lateral view you'll be able to see. Okay. Then what else do you want? Mm. Yeah. So, basically, if there is like white, that will come in the next. Okay. So we'll go to the next one. Um. So then we classify based on the extent of the lung involvement. So there can either be um involvement of a lobe, okay, or a segment or subsegment. There can be involvement of a lobe of the lung, or there can be okay, atelectasis of the entire lung. Okay, so what do you guys see in this X-ray? This which X-ray? I wanted, I'm not gonna say it. Anyways, yeah, yeah, I guess there's cardiomegaly. Not, yeah, there is cardiomegaly. That's true. Okay, yeah, there is air under the diaphragm. So what could that be on both sides? Well, this patient just came from surgery, Falcon. No, it's not. It's not all. So basically, what happens here? Happened here. Okay, basically, okay, and okay, forget those. Forget the air under the diaphragm. Are all the ribs visible? Normally the ribs that have to be seen. No. Okay. Yes. Okay. So basically, this patient has had an. So usually we say that if there is air under the diaphragm, there's rupture. Okay, that's why there's air under the diaphragm. But this patient has is a post-op patient. He had an abdominal surgery. So because he had an abdominal surgery, right now he has air under the diaphragm. Okay, so that could also be a cause of air under the diaphragm. Yeah, it's iatrogenic in a way. Like this is a post-op patient, so he had an abdominal surgery, so that's why he has air under the diaphragm. Basically, what I wanted to show on this X-ray is that you can see there's also reduced lung volumes. Okay, so this is not a maximally inspired film. And the patient is not able to maximally inspire because he's in pain. So if a patient is not able to maximally inspire, he won't be able to open up all his alveoli. Okay, so there'll be segmental atelectasis, like not of the entire lobe or not of the entire lung. Okay, okay. Yeah, okay, but not of the entire lung. But like some, you can see these lines over here, over here, over here. Okay, these lines, these are actually atelectasis. Okay, so these are like atelectasis of a particular segment because the patient is not able to like inspire completely. Like he is not able to breathe to his full capacity. So there's a atelectasis of a segmentals or some sub segments of the lobes. Okay, so that's what I wanted to show here. Okay, then there can be atelectasis of an entire lobe, saw in previous things. Okay, then this one is, what is this X-ray? Not lung. So it's not an effusion. Okay, there is a question like this in you step 2 CA. Everyone gets that wrong. Everyone. Okay, so no. So this is actually total lung atelectasis. Okay, so the reason this is not, you can see that this is pleural effusion is because they deviated towards the side of the lesion. It was, if it was deviated away from the side of the lesion, you say it's pleural effusion, but this is not pleural effusion. Since the trachea is deviated towards the side of the lesion, it is actually atelectasis. So suppose if there's some bronchial mucus plugging like the left bronchus itself, and then the whole lung has atelectasis. Okay, so this is total lung atelectasis. There's a question like this in New World, which everybody gets wrong because everybody calls it pleural effusion. Okay. Hmm. I don't know the QID one. Why would I remember QID? But I'll check. I have the X-ray of that one. I didn't put it over here. How did the patient not notice? Anyways, yeah. So this is the thing that's causing the obstruction in that lateral view. Okay, now a few more signs. We'll finish this quickly. Okay. Okay, so this is the thing we saw, like the lobar obstructive atelectasis. So in obstructive atelectasis, actually you see the sign called the S sign. This one called the golden S sign. Okay. So basically, this border that you're seeing, it is caused by the pulling up of the fissure. Okay, so the horizontal, I think the horizontal fissure is pulled up because of the atelectasis. It's supposed to be somewhere over here. It's got pulled up by the atelectasis. Okay, so so basically, what this S sign basically means is that because of the atelectasis pulls the fissure up, so you get this edge. Okay, but then the thing that's causing the obstruction, the mass, it tries to keep the fissure on its same place. So you get this edge. Okay, so you get like a reverse S sign. Okay, so that is called the golden S. So this is because of the atelectasis trying to pull up. Okay, and this edge is because of the mass trying to keep the fissure in its place. Okay, so this is the golden S sign. I have no clue why it's golden. I forgot to Google that. I'm supposed to Google it. I'll tell you. Okay. Okay. And the other sign that you see is called the tenting sign. You see the diaphragm, this diaphragm. Okay. It is tented up. So this is also because of the atelectasis. It kind of pulls the remaining lung tissue and everything up. Okay. So there is a tent of the diaphragm over here. This is called tenting sign. Okay, pulling up the diaphragm superiorly. We just touched it. Okay. 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 Okay, now I'll move to the next one because we're almost an hour into it. Okay. What is the next way? Oh yeah. Okay, now I know. Do I know? Yeah, yeah, now I know. Yeah. Okay, what is this X-ray? Tenting sign is it's not very visible on lateral view. It's more yeah. Okay. Okay, so this is I told you in the beginning that sometimes in atelectasis there is compensatory hyperinflation of the. So here there is an atelectasis of like the upper lobe. Okay, but there is also an what do you say? A translucency over here. Can you repeat? Oh, the tenting sign. You guys heard till the tenting sign? No, after that. Okay. So basically, in the beginning, I was talking about how in atelectasis there is hyperinflation remaining part of the lungs. Okay. So yeah. Okay, it's the remaining part of the lungs. Okay. So over here you see there is some atelectasis in the upper part of the lobe, which is more visible in this one actually. Okay. Then there is translucency over here. Okay, so this is the compensatory hyperinflation. This is the upper lobe. There's atelectasis over here, and this is the lower lobe side. Okay, and you can see it's hyperinflated. Okay, yeah. So this is called this is also called a sign. It's called Lufsichel sign. Okay, so this is translucent area above the opacity represents the hyperinflated of the superior segment of the left lower lobe. Okay, yeah. Well, at least we're learning to spot something on the chest X-ray, if not anything else. Yeah, I think I'll post them in one sign a day, one by one after the class. Okay, it's not even important. You just need to know. I don't think. Okay, I'm gonna move now. Mm, okay, I think I'll skip this one. Okay, but this is okay, and I'll just not skip it. This is this is pleural plaques actually. Okay, pleural plaques. But which in which condition do you see pleural plaques? Asbestosis, yes. Okay. So it's not like you cannot say asbestosis, but you can say asbestos exposure. So this pleural plaques, they kind of give the appearance of a holly leaf, apparently. What is it called? Holly leaf, sorry. Okay, holly leaf. Something that looks like this, that leaf. Okay. So yeah, this is pleural plaques. I don't know, I just kept it in the middle. This is not that important, we'll just skip it. Okay. Then we come to solitary pulmonary nodules. Okay. Okay. Okay, so where do you guys see a solitary pulmonary nodule in this? Yes, where do you see it? Yes, in the right, almost hilar mid zone. This is the solitary pulmonary nodule. So what are the possible causes of solitary pulmonary nodule? And what solitary pulmonary nodule is basically something that is equal to or small less than 3 centimeters. Okay, that is a solitary pulmonary nodule. So okay, coronation, yeah, cancer. It could also be benign hamartoma, granuloma. Yeah, if it's changed. So how? So yeah. So now we'll come to that. Okay. So all of these can be the causes of solitary pulmonary nodule. They can be cancer, can be a solitary pulmonary mets also, granuloma, pneumonia, AV malformation. Okay. So if you see a solitary pulmonary nodule on the chest X-ray, what are you supposed to do? Yes, mets are usually multiple, but they can also be single as well. Yeah. So you ask if the patient has an old X-ray. Okay. So you compare with any previous X-ray. Okay. So when do we suspect malignancy? Okay. So we suspect malignancy if, as Rankar, there is growth over a period of time. If it's getting bigger and bigger, okay. Or if there is a lack of calcification, that also points to towards a, more towards a malignancy. If there is adjacent rib destruction, that points towards a malignancy. If there is associated adenopathy, associated pleural effusion, or a thick walled cavity, that also points towards a malignancy. Okay. Mm. Do you guys see any solitary pulmonary nodule over here? Okay, so yeah, it's kind of not visible. Not in the left middle. Maybe, yeah. Yeah, I think it's that one only. I forgot to write where the nodule was. This is the nodule. Okay. I think it's the left middle one only. I think he's right. Or was it this one? I thought it was this one. No, this one actually. It's this one. I don't know. Or is it this one? Oh no. Maybe it's that. Maybe it's this. I'll check and tell you guys. Now I forgot which one was it. I think it's because here it's located in like okay. Okay, so I don't know why I put this thing up. We'll just skip this one also. Okay, I'll tell you guys about it later. Okay, so this is the internal growth. Okay, so this guy said that he doesn't. They saw a solitary pulmonary in the beginning operated, so they just followed it along and saw it grow. So, so if it's growing like this over a course of a year, okay, so then it's more likely malignant. Okay, malignant. Okay, but if there is no growth in 2 years, means the same in 2 years, then it's most probably benign. Okay. Uh, all right, so that is internal growth. Okay, then yeah. Okay, so now this one, this nodule over here. Okay, it's very well defined and it's very opaque because it is densely calcified. Yes, right lower. Okay, so this dense calcification mostly points out to a benign etiology. Okay, so the same X-ray CT scan, you can see how calcified it is. So this is basically a hamartoma. Okay, it's densely calcified. So if it's densely calcified, it's less likely to be malignant. It's more likely to be benign. Okay. Then okay, okay. Now what about this? Where do you see the left middle? Correct. Do you see anything else? Very small, subtle things. Like, what would you say? Is this probably benign or probably malignant? Do you see any features of malignancy in this one? It is not calcified. That's correct. The ribs are relatively okay. Okay. What about the costophrenic angles? Yes, blunted on which side? Yeah. The right one is blunted. Okay. So this there's a right pleural effusion, and there's another nodule over here also. Okay. So this is metastasis of this nodule over here. Pleural metastasis and metastasis to the adjacent lung. Okay, so this is more likely to be a malignant nodule. Yeah, I don't know. I think it's just maybe there's something happening over here also. Anyways, yeah, so you can end up missing the right one, right? So that can happen. Okay, now this one. What do you guys see here? my goodness. Anyways, well, we should not laugh at these jokes, but they're so funny. Anyways, yeah, what is this X-ray, guys? What do you guys see? Yeah, there is a nodule in the left upper. Okay, and actually, let's just go to the next. Yeah, okay, so there is this nodule opacity in the left upper lobe, and there is also destruction of the ribs adjacent to it. These ribs are there's destruction. Okay, so this is features of malignancy. It's if it's more opaque, it's calcified. This is not very calcified. That one was calcified, which we saw. It's more opaque. Like you have to compare the opacity. If it's as opaque as the bone, then it's calcified. Okay. All right. Then what is this? Mets. Yeah. Multiple pulmonary nodules, most commonly caused by metastasis. What is the organ that what are the organs that most commonly metastasize to the lung? Yes, breast. Okay. Breast, colon. Um, what else? Yeah. Okay. Mm, okay. Okay. Now, what are other causes of multiple pulmonary nodules? TB. Think so? Mm. Yeah, TB also. Okay. Then mostly fungal pneumonia. Did I put a picture of that? Okay, fungal pneumonia and stuff. Yeah, sarcoidosis. Anyways, then I'll move to the next. What do you guys see here? Yes, there's meniscus sign, correct. What else? A little bit over here also. What is this? Do you guys see something here? Yeah, this is air bronchogram. Okay. So basically, as I said, air bronchogram, it is a definite indication of some intrapulmonary pathology. Okay, so like there's something present inside the lung tissue. Okay, that's when intra. Yeah. Okay. I think it's not visible in your stream, but when you see the file, it'll be more visible. That's how it is. Okay. So basically, this intrapulmonary thing can be like there can be collection of anything. It can be pus, it can be pneumonia, it can be fluid, it can be blood. Okay. So then you will see this meniscus effusion, like effusion kind of a thing, and you will see these air bronchograms. Okay. Like you won't know what it is. You'll have to do put a chest tube to see. Yeah, it could like empyema, yeah, but empyema is present in the pleura, so it'll be mostly limited to one, be like a long thing. This is like in the lung. Okay, now I'll just do some very very quick stuff. Okay, we'll finish it in like 10 minutes. Okay, so now in pulmonary embolism, we actually don't just X-ray to diagnose pulmonary for diagnosis. What are the investigations that we use in pulmonary embolism to diagnose if we suspect pulmonary embolism? Yes, we do D-dimer to rule out if there's low probability. Suppose if we suspect, then we do CT pulmonary angiogram. Yes. Okay. So, but suppose if we do not suspect, and if we're just like doing chest X-ray, okay, then if what are the signs that we'll see that indicate pulmonary embolism? Okay, so one, and this is like rare. I don't think it's not that important. Okay, but then anyways, okay, so there's this thing called Hampton Hump sign. Okay, so Hampton Hump sign is basically it's like this saddle sign. Yeah, Hampton Hump size is basically this sharply demarcated wedge-shaped. Okay, so that is Hampton Humps. Okay, subpleural wedge-shaped opacity. Okay, that is Hampton Hump sign. Oh, this X-ray has a lot of things. Okay, what else do you guys see in this X-ray? Cardiomegaly, correct. What else? Where? Okay, what else? Silhouette sign. That is because of something else. Trachea? Is the trachea okay? Right costophrenic angle blunted, yes. But that is, I don't know if it's blunted or if that's breast tissue again. I don't know. Because it's actually pretty sharp over here. Okay. Trachea is shifted, yes. Okay, so trachea is shifted. What is this over here? The aortic knob is enlarged. We'll study that next class. Okay. Okay. So yes, the aortic knob is enlarged, and because of the enlargement of the aorta, the trachea is shifted. So what could be the cause of enlarged aorta? It could be due to aortic aneurysm. Okay, so this patient has an aortic aneurysm, which is causing the aortic and lobe to be knob to be enlarged. Okay, and that is causing the shift of trachea. Well, according to the yeah, due to aneurysm. Okay, then actually this patient also has scoliosis. Okay, so if you see the spinal process, this patient also has scoliosis. I'll show in this one. Okay, okay, yeah. So the heart appears enlarged, and there's a large and there's tracheal deviation to the right side, and the patient also has scoliosis. Okay. Then there are other signs. Because of the pulmonary embolism, the area beyond the pulmonary embolism will not be well. So there will be a hyperlucency in that area. Okay. Could you repeat the Hampton Hum sign? Hampton Hum sign is basically wedge-shaped opacity, sharply demarcated wedge-shaped opacity in the subpleural region. That is Hampton Hum. That's all. Okay, and then there is something called Westermarck sign. Westermarck sign is area of increased translucency downstream to the pulmonary embolism. So if you can see, there's increased translucency in this area. Okay, so that is Westermarck sign. Okay. Mm, then Fleischner sign is, I don't think these signs are so important. I'm showing this. Okay, Fleischner sign is because of there'll be prominent pulmonary artery because of vessel distension because of a pulmonary embolism. Okay. Okay, what is this one? This extra. We'll finish in 5 minutes. Okay, by 3 o'clock. 5:30 we'll finish. Okay. Yes. 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 That's how you guys are supposed to say it. Okay. So why do you guys say COPD emphysema? Why do you say it? Yes, because there's hyperinflation. So what makes you think that there are hyperinflation? Okay. So basically, signs of hyperinflation is there'll be hyperlucency of the lung tissue, there'll be correct, there'll be flattening of diaphragm, the ribs will be more widely spaced, intercostal space will be increased. Okay, and if you see the lateral view, the AP diameter increased. Okay, so these are the causes of hyperinflated chest. It's most commonly caused due to COPD, severe exacerbation of asthma, emphysema. Okay, okay. So now we'll do COPD only. I mean hyperinflation only, but some other details. Okay, so this is again hyperinflation chest. Okay, but so this is the PA view. Okay, can you guys say some? Okay, I'll just say okay. So basically, this is actually like this is emphysema and this is central emphysema. Central. Why do you, why what is the feature differentiating feature between central lobular and panacinar emphysema? Like how is central lobular emphysema different from panacinar? Which one is caused due to smoking? Which one is caused due to alpha 1 antitrypsin deficiency? Yes, centrilobular emphysema is associated with smoking. Okay, and panacinar emphysema is associated with alpha 1 antitrypsin deficiency. Okay? Why does this look weird? Anyway, okay, yeah, yes. So in centri because centrilobular centri acinar or associated with smoking, mostly the upper lobes will be affected. Okay, decrease lucency in the middle, left middle. Yeah, I don't know why this decreased. But what this X-ray was supposed to show us was that there is more the translucency because of hyperinflation, everything. But the translucency is supposed to be more in the upper lobes in central lobular emphysema. It's actually more properly. It's actually more properly. This is the lateral view of the same X-ray. Okay, so you can see more properly in this one the increased translucency in the upper lobe, right? Are you guys able to appreciate that? Yeah. Okay, so so that's why so if upper lobes are more translucent and more emphysema is more in the upper lobe, then it's mostly centri lobular emphysema. Okay, yeah, you can see it more clearly. Okay, if you're not able to see it, you can see it in the file that I send it. Because last time when I was seeing it, I was like, I'm not sure what I was. So I think it's because of the stream. Okay, okay, then okay, so that is central lobular emphysema. Now in this one, are you able to see the difference? So here the lower lobes are more translucent. Yeah. So this is panacinar. Yes. Okay. So this is panacinar emphysema. Yes. Okay. Yeah. Yeah. I think that's it. That's it. I kind of left out like interstitial lung disease. I'll do that next class. I prepare for it and pulmonary edema. Yeah. I'll do it in the next one with cardiac. I didn't get time to prepare for that. Okay. Anybody has any doubts? Well, okay then I'll switch off the stream.